only rising, not only in the country but worldwide. And I also chose to talk today because I too am a survivor, also a caregiver to my late aunt, and now a healthcare provider in the cancer field. So we thought we could shed light on very critical facts, being what it is, how it's caused, what are the risks, what are the protective factors, how can it be diagnosed, how can you prevent it even before it starts or even at a very early age, how can you get treatment. So you get that sort of roadmap, and how can these people go back into society to not only survive but to thrive. So our aim is to shed light on all of those things, to bridge gaps in understanding. We also want to reduce the stigma patients in our communities have. And that's only done if we have the knowledge. So to do this, I have two very good friends and speakers. One of them is Dr. Amina Kedei. She's one of my bosses at the Aga Khan Hospital. She's a medical oncologist. So she'll be talking about the various types of treatments and also other insights into what is being done in the country and beyond. And then we also have Dr. Rupre, who I'm sure many of you know from our community. He'll be talking about the diagnosis, how biopsies are done, and also the surgical management. So I'd like to just welcome them onto the stage, and then we can get started. Yes. So I'll start this presentation and then I'll hand over accordingly. We'll have a question and answer section at the end of this presentation. So I'd really encourage you all to ask anything. We welcome any comments, any questions, any opinions, even any testimonies and experiences that you might have. So we can duly address them. And also, if you feel certain information is sensitive and you don't want to discuss it and it's private, we'll stay back and you can approach us and ask. Okay? So, what are cancers? What are tumors? What are these words? What are these words that we're always hearing about? To start, I think it's important to know that we're all made of cells that make up tissues and organs. These cells divide and grow throughout. And now tumors occur when the normal cell growth and division is impaired, is dysregulated. And that causes just an abnormal growth to happen. Tumors can be broadly classified into two. One is benign. These are still growths, but they remain localized in one place. They can still bring issues depending on the area they are, because they can cause a compressive effect in the bodies, and depending on the structures around, there can be symptoms caused because of that. And then we have malignant tumors or cancers, which when you look under a microscope, these cells do not look like the cells they were before. Two, they have the potential to invade where they were, so they can invade the floor and cause destruction. And three, they have the potential to spread. And how do they spread? They spread by either lymphatics, which are sort of sewers or additional spaces in our body that go to lymph nodes, which are like police stations or where the sewage banks. Or they can spread by blood. They can go through the blood and then they can go to various organs. And then sometimes they can spread around the cavities they are in. So cancers bring about illness because of that potential, and if they go to organs and destroy them, then those organs can get damaged, and if there's extensive damage, that's what causes illness and even death. So it's important to know that cancer is not one disease, it's a group of diseases. In fact, there are more than 200 cancers that have been that have been classified. And these cancers can be both solid ones that come from solid organs, or the blood ones like leukemias and lymphomas and myelomas that you probably heard of. So solid cancers are the ones that spread the way I described. So what is the burden of cancer? Globally, just by WHO statistic done in 2022, there were about 19.9 million diagnoses of cancer made worldwide. And out of those, 9.7 million deaths. The most common cancers were in that year were lung, breast, colorectal, and then prostate. Lung cancer had the highest amount of deaths, followed by colon, liver, stomach, and breast. For children, it's estimated that almost 400,000 children get diagnosed every year, globally. What is the picture like in our country? In our country, in that same year, 2022, there were more than 44,000 cases. And out of this, close to 30,000 deaths. In Kenya, the most common cancers we have are actually breast, then cervical, then prostate. And the leading cause of death in our country is actually, in that year actually, 2022, was prostate, followed by cervical and breast. So we do have these very common cancers, we do have these very high numbers, and we do have these also shocking number of deaths. So what causes this? What causes these diseases? What causes this condition called cancer? So that growth is altered, and that is caused because of different mutations. In each cell we have like a ribbon of genetic material. These make up how we are in totality. And these ribbons sometimes get damaged. But you can also inherit from your parents, from your grandparents, from your great-grandparents, these mutations. And you can also get mutations from the environment, and these are acquired. And those ones include, and these are termed as carcinogens, the ones that have the capability of causing these mutations and damage. They can be physical, like UV light, especially for skin cancers. They can damage the DNA in the cells in the skin, and also radiation. And radiation can be from different sources, but we're actually talking about gamma radiations that cause that damage. And then you can have chemical carcinogens, including in smoke, tobacco, the pollutants we have in our environment, alcohol. There's a toxin called aflatoxin that I'm sure maybe many of you have heard in the news. But sometimes the maize flour, the ugali flour kept in the silos can sometimes have these contaminants caused by different fungi, and that when in high amounts and ingested by people can cause can be carcinogenic. There have also been other agents, and I think it's important. So one I wanted to mention is a lot of our people in our community work in different industries. So there is a compound called arsenic. It's present in alloys, electrical and semiconductor devices, also insecticides. That is carcinogenic. There's also a compound called asbestos, and that's also found in brake linings and fireproof material. Many of us do mechanical work. That has the potential to cause like a lining of the lung cancer. There's also benzene in paint, different adhesives, coatings, and detergents that mainly we handle at home, but also some people can handle at their work. These are all carcinogenic compounds, and they have the potential to cause these damages. And then there's also biological carcinogens, which are mainly viruses in our environment that can lead to these mutations. So we talk about causes, but we should also talk about risks. Causes can actually cause those mutations, but risk are factors that can increase the likelihood of developing cancer. It doesn't mean if you have this risk that you'll develop cancer. So we talk about risks, and it's important because we know that some are modifiable and some are not. They're beyond our control. What are the modifiable risks that we can look into and we can avoid? This is tobacco, alcohol, some of the diets we take, like a lot of fatty diets, a lot of even red meats, depending on the way they're prepared especially, have the potential to increase the risk. Obesity, because it can cause some hormone dysregulation. Environmental exposure such as the ones I mentioned. And then some chronic infections which have been documented to actually cause. So the main ones are, there's a virus called human papilloma virus that has been heavily implicated in causing cervical cancer, but also other linings of the mouth, the esophagus, because it tends to like those surfaces. Hepatitis B, which can cause liver cancer because it's a virus that goes into the liver cells and our DNA and can cause that. And also H. pylori in the stomach that can cause chronic inflammation that is just a fertilizer and breeding ground for mutations to happen. So these are things that we can to some extent avoid, and they are modifiable because we can choose like what to take, what to eat, what we're exposed to some extent. But there are other things that we can't, and one is age. I mean, age is inevitable. I think if we had the potential to stop that, all of us would be young. But with age, it's just beyond our control. And what happens is many of the cases that I showed, the pictures, the cancer diagnoses are higher in the elderly. So from 45 and above, even to the 60s, the rates are higher. Why? Because there's an accumulation of mutations in cells that occurs with time. So we can't change that, sadly. There's also some genetic predisposition and inherited genes that we might get. We can't choose that. I mean, no one has that choice. And of note is when some people have specific mutations that can predispose themselves to not only one cancer but a number. So they can have a syndrome. Like there's maybe Dr. Amina will talk about BRCA mutations, but that's something that if you have a relative or someone with that mutation, then even your chances, if that mutation is present, are higher, developing those certain cancers. And then hormone influences. Especially for breast cancers and prostate, they can be hormone, like female hormone dysregulation and male hormone spikes that can increase the chances. So that we don't have control over because we can't dictate the hormone regulation ourselves. So what are the preventive and protective factors we can do? So we look at prevention into three. We look at primary prevention. Just today, by us getting aware, that's a form of primary prevention. So actually having the knowledge is a form of primary prevention. But also knowing the risk factors and avoiding that's primary prevention. We know, I've mentioned some of the viruses that can cause cancers. There are some vaccines that now can lower the chances of you developing those associated cancers. One of them is hepatitis B, which is mainly provided to people with high exposures, like even the healthcare providers. But also there's one which has been there for some time, which is the human papilloma virus that can be given to our young girls and even boys, just because if they get into contact with these viruses, their chances of clearing it are easier because they already have some previous exposure and an immune response towards. So that's primary prevention. Then there's secondary prevention. So that's through screening, and Dr. Amina will take us through what we can do for screening of certain cancers. And then tertiary prevention. That's about if you're found with a cancer specific or even early detection or screen detected, it's about treating it so it doesn't go and progress further. So the protective factors are basically directed towards avoiding risk factors. So that's about, we can try to optimize our diets. We can try to do physical activity, and that's both aerobic or cardio exercises and weight trainings. We can avoid the substances to the best extent possible, avoidance of UV light through sun protection, safe practices for hepatitis and human papilloma virus, and even vaccinations, and then ensuring that we have safe and appropriate use of radiation. I know there's when you go for x-rays and all, there is that level of protection that you might get to certain areas if it's not going to be exposed, but also to the healthcare providers. They are provided with that protection, so because they deal with a lot of scans every day. And then it's about, if you have an issue, please seek care. Like, if it's bothering you, even minorly, please get it evaluated before assuming. So with that, I would now like to hand over to Dr. Amina to lead us on to the subsequent part of the presentation. Thank you.
Good morning, everyone. Thank you for having me. Thank you, Dr. Chana, for inviting me to create this awareness. As he mentioned, my name is Dr. Amina. I work at Aga Khan University Hospital. I'm a medical oncologist. That's a cancer doctor. And so he's given me the bit for screening and early detection. So for screening, number one, unfortunately, a lot of cancers are diagnosed very late. So by the time patients are coming to us, it's advanced disease. And for the most part, what we can do is just to control the disease as a chronic illness. However, we are still fortunate in that the 4 most common cancers in the world, particularly in Kenya, our part of the world, we have cervix, breast, prostate, and colon. That's the intestines. So these are the most common cancers in Kenya. We don't see a lot of lung cancer. So, you know, when you're going through maybe the media, any print, you might see that in the world, the most common cancer is lung cancer, but that does not reflect in Kenya. So with this, we are fortunate enough to be able to screen them, and we'll just go through that. So for breast. So for breast cancer, the very common recommendation is to start screening at the age of 40. This is mostly by mammogram. It's very sensitive. And, you know, there's this sensitization for women to first of all understand the architecture of the breast, to know how their breasts feel like, especially with the monthly variations. So it's good to first know that for yourself. Unfortunately, by the time a woman is feeling a lump in the breast, it's already a bit too late. So that's really the essence of early screening by mammogram, because it's able to detect something very tiny that you cannot be able to feel it with your hands. So this is usually done annually. What is recommended is from the start of 40 years old, because earlier than that, the breast tissue is a bit too dense and we may miss something on a mammogram. That being said, some women have different indications for earlier screening. So for example, they carry a genetic mutation. So one of the most common is the BRCA mutation. I know a lot of us are familiar with Angelina Jolie. She carries this mutation. We are able to test it in Kenya as well. So for this kind of women, we recommend much earlier screening, even at the age of 30 years. And this can be done even by MRIs, you know, a bit more advanced imaging techniques rather than the mammogram that's starting at 40 years old. Oh, sorry. So that being said, this is the October Breast Cancer Month. So I'd encourage all of us here to be sensitized to this, the women in the room, the men, to please inform our family members, friends, and colleagues and encourage them for screening. For colon cancer, this is much simpler. We just do a stool test to detect if there's any blood, and the specific blood that's tested is actually coming from a colon tumor. So that's usually very simple. Unfortunately, in the past several years, we've been seeing a lot of early onset colon cancer. So initially, the age of screening was from 50 years of age through a colonoscopy, which is essentially a camera that goes through and screens the whole of the intestine. However, now we are seeing very early onset colon cancer. In fact, we have a patient who's only 28 years old with colon cancer. So it's advised at least every annually screening of fecal occult blood test. That's essentially just checking blood in the stool. And this can be done as early as 30 years or even in the early screening, the annual screenings. So, but for the colonoscopy, sigmoidoscopy, what is recommended worldwide is starting from 50 years old. But now in the African setting, they've noticed actually our colon cancer starts much earlier. So what we've been recommending is at least 45 years of age to start the colonoscopy screenings. And so one, it's not very uncomfortable. Actually, patients are mostly sedated. Two, if there's no abnormality that has been detected in the colonoscopy, the next one that's recommended is after 10 years. So, it's just a once in 10 years sort of screening, which can save a life actually. Is that it? So let me just speak of prostate and cervical. I don't see the slides here, but so prostate cancer, most common test that we do is the PSA test, and it's a simple blood test. This is done annually. I recommend for it to be done annually for any men above 40 years of age. Again, we see a lot of highly aggressive early prostate cancer. So if you look at data worldwide, you'd see like prostate cancer is mostly diagnosed 67 years and above, but for us, we've seen patients 40 years. And the unfortunate thing about our part of the world is we don't have data that we've collected in good registries to inform us the early screening or essentially the screening protocols. So any man above 40 years old, when you're doing your annual screening, please request for a prostate cancer test. It's a simple blood test done within an hour, and it's good to just follow up from a baseline of 40 years. Cervical cancer, very, very important. It used to be #1 cancer in Kenya for women. Right now that has been surpassed by breast cancer. So we know about pap smears, we know about the HPV testing. Again, it can be uncomfortable, but again, you only get to do it once in 3 years. So, by the time we're getting a cancer to be the most common cancer in the world, that tells you about our culture, our patterns of screening, and it is completely preventable. At this point in the Western world, they have a vaccine, and it's almost completely eliminated. In fact, the WHO, they're targeting up to 2030 to completely eliminate cervical cancer. This happens from the prevention of vaccines, screening as well. It's not a practice that has picked up very well in Kenya, but totally preventable, avoidable deaths from cervical cancer. So I'll just hand over to my colleague to speak on his bit on the surgical aspects of it. Doc?
Sat Sri Akal, everybody, and a very good morning to you all. My name is Dr. Ruprai. I'm a general surgeon, and I run a private surgical practice which involves many hospitals, including our Guru Nanak Ramgarhia Sikh Hospital. I'll take you through a few of the warning symptoms and signs, especially in the adult patients. Remember, early detection will save a life. So if you have come up with a lump or bump, whether it's suspicious or no, it's best to get it checked. Often what happens is we ignore simple lumps and bumps, well, unless it's a mosquito bite, that's excusable. However, any new change in the body accounts for a medical check. Recognizing warning signs can lead to earlier diagnosis and better outcomes. Both adults and parents and family members should be aware of the warning symptoms of abnormal growths. In children, the parents are usually responsible for their hygiene. So during bathing, anytime that you notice any unusual lump or swelling or any part of your child's body, that must be checked. Often you will come across lumps and bumps around common regions around the neck, okay? Those could just be either innocent lymph nodes or they could be a sign of an early disease. Any easy bruising or bleeding, especially of the gums or skin, unexplained paleness, ongoing pain in any area of the body that persists for longer than it should, unexplained fevers, night sweats, and weight loss. Let me take you through how cancer is diagnosed. So the diagnostic journey is a multi-step process which confirms the presence of cancer, determines the type and extent, and guides the treatment decisions. Remember, to destroy the enemy, you must get all the information, every information possible, so that you can mount a thorough and a complete fight. So an accurate diagnosis is crucial because it provides prognostic information and informs on the most effective treatment strategy. The key components of the workup for any suspicious lump or bump or in a cancer patient, first of all comes the patient history and physical examination. That's why it's very important. Anytime you notice an abnormality on the body, seek medical advice as soon as you possibly can. The doctor will then order some tests after the physical examination, which may include some lab tests, which are blood, urine, or stool, or a combination of the same. Imaging studies that include your X-rays, ultrasound, CT scan, MRI, PET scan, and the likes. Biopsy and pathology, staging and grading. I'll take you through each of them. So in the clinical evaluation, that is the history and the physical examination. In the medical history, the doctor is going to ask you about the symptoms. Remember, the symptoms of cancer are usually diverse and can overlap non-cancerous conditions. Fatigue, weight loss, pain, abnormal growth, all those might be symptoms related not only to cancer but other illnesses as well. So the doctor will ask you about your family history and the risk factors for developing the abnormality. On physical examination, there's a head-to-toe check for signs of malignancy, such as the suspicious lumps, enlarged lymph nodes, or organ enlargement. Then there is the directed exam, which Dr. Amina had focused on. Depending on the type of cancer, the directed examination could be the breast exam, a digital rectal exam, or a vaginal exam. So on the blood tests, there is the blood chemistry tests, which measures the substances or chemicals released by organs and tissues to assess their function and to detect abnormality in the same. The complete blood count, which everybody is familiar with, measures blood cells. Abnormal counts can suggest cancer, such as if your white blood cells are elevated, they could be elevated by either an infection, or if we are thinking about cancer, yes. Tumor marker tests are very specific. These are chemicals produced by cancer cells in the body in response to cancer itself. Some of them are very specific, others are non-specific. They can be used for monitoring, and usually are not on their own used for definitive diagnosis of cancer. So the examples are the PSA, which Dr. had mentioned. There is the CEA, that's carcinoembryonic antigen for colon cancer, CA125 for ovarian. Then there are others like CA53 for breast. The definitive test for cancer is biopsy. So a biopsy is a procedure to remove a tissue sample for microscopic examination. Remember, the other evaluations, the physical examination, the laboratory tests may indicate that we're dealing with cancer, but unless we have a biopsy which checks the cells under a microscope for abnormalities, you don't have a definitive diagnosis without the same. The types of biopsies that we have, there's the needle biopsy, where you use a needle to extract a small amount of tissue or fluid. There is the endoscopic biopsy, where a camera is inserted into one of the orifices of the body, and thereafter there's a small amount of tissue which is checked for cancer. And then the surgical biopsy could either be incisional or excisional. Excisional usually is curative. Incisional takes a small part of the affected tissue to confirm abnormal cells. The microscopic evaluation is the responsibility of the pathologist. This is a doctor who specializes in evaluating tissues and cells to diagnose diseases. The biopsy sample is prepared and examined under a microscope, and the pathologist will look for the presence, type, grade, and extent of cancer cells. There are other tests that are usually done on the tissue and the cells, which include immunohistochemistry. Remember, like I said, you must get all the information about your enemy before you mount a fight. Then the pathologist report guides the clinical team in developing the treatment plan. So the imaging that we often use in cancer detection is X-ray, which can be used for screening purposes, such as the mammogram. The mammogram is essentially an X-ray of the breast. There's the CT scan, which we are all familiar with. It's useful for finding tumors and assessing their extent if the tumor is located within or confined within the organ affected, or is it something that has spread beyond its contain. The MRI uses powerful magnets and radio waves, similar to the CT scan, but it's usually more sensitive for soft tissues, such as the breast. Ultrasound uses high energy sound waves. Well, an ultrasound can be used as a screening tool for the younger women, as opposed to the mammogram. In some cases, we often advise that we do both, an ultrasound as well as a mammogram. And then the PET scan. So when it comes to cancer staging and grading, there's often some confusion, and the moment someone's diagnosed with cancer, we often ask the question, or what stage is it at, or what grade is it at? So staging describes the size of a tumor and the extent of spread from its original location. We often use a TNM staging method, which describes the size and extent of the main tumor, that's T. N stands for the nodal spread, and M stands for the distant spread. So therefore, stage 0 means that abnormal cells are present but have not spread. Stage 1, 2, and 3 will signify either a localized cancer or a locally advanced disease. So where you have, let's say, a cancer detected, say, in the breast, and there is spread of that cancer to the armpit, then we say that that's a locally advanced cancer. Whereas if the cancer has spread to a distant organ, such as the liver or the lung, that we call stage 4, meaning that it has spread to distant sites. The grading gives us the information of how abnormal the cells are to the original type. Remember, the worse the abnormality, the more aggressive the illness. So well-differentiated cells that look very similar to normal cells, but there is an abnormal multiplication, is grade 1. So moderately differentiated means some of the features of the cells are distorted. That would be grade 2 or intermediate. Then we have poorly differentiated cells that look very abnormal and grow very quickly. Those are grade 3, and grade 4, these are just undifferentiated cells not looking like the normal tissue. How we usually manage cancers and how we discuss the the staging, the grading, as well as the evaluation, we form multidisciplinary team boards and meetings where we have collaborative care. So the diagnosis and workup of cancer involves a team of specialists to ensure that there is a comprehensive and a patient-centered personalized care. So the key team members are usually the oncologist, the radiologist, the surgeon, oncology nurse, pathologist, and other supportive members, such as the psychologist and the social services. So in summary, cancer diagnosis is a complex process involving a careful clinical history, physical examination, and advanced diagnostic tools. A definitive diagnosis requires a biopsy, with pathology providing crucial details on tumor type and characteristics. Staging and grading help determine the extent and aggressiveness of the cancer, guiding treatment strategies. The entire workup and treatment process is a collaborative effort by multidisciplinary team boards. So I'll take you through the surgical oncology. So cancer treatment depends on the cancer type and stage. Surgery is usually involved mainly in solid organ cancers. So cancer treatment involves surgery, radiation, chemotherapy, targeted therapy, immunotherapy, and palliative treatment. So I'll take you through surgical oncology. This is the field of cancer care that is focused on the surgical aspects of cancer. That includes diagnosis, whereby the surgeon is the one responsible for usually obtaining the biopsy, whether it's taking a small part of the diseased organ or removing the entire tissue, which is often, like I said, curative. So staging, treatment, and symptom management. So the goal basically is to remove the cancer tumor completely with clear margins. That means that if we are suspecting or we have a confirmed case of a solid organ cancer and we want to surgically excise it, we usually remove a rim of normal tissue around it. So that's what we mean by clear margin. So if you have a report that says that the tumor was removed with positive margin, that means that some of the tumor has been left behind. So the evolving role of the surgeon is in prevention, diagnostics, staging, and surgical excision. So principles of cancer surgery is, like I mentioned, complete resection, removing all visible cancer, and a margin of healthy tissue confirmed by the pathologist on microscopy. Lymphadenectomy means the removal of nearby lymph nodes. So thereby, often when we are doing surgery for breast cancer, it is not unusual for the lymph nodes in the armpit to be excised as well. The surgical approach is tailored to specific type and stage of the cancer, and we try as much as possible to preserve the function of the organ so that we have retention of the quality of life. Roles of surgery at different time points, I think, have mentioned all that, so I'll not go through that slide. Again, types of cancer surgeries. Our aim is to provide a curative treatment. That means that we remove the entire tumor and the surrounding tissue with a negative margin. We can sometimes do something called a debulking surgery, which is common in gynecological malignancies, such as cancer of the ovary, where we remove a large portion of a tumor that cannot be completely excised. Debulking is often used in neuro surgery as well for brain tumors. The remaining tumor is then treated with other therapies such as chemo or radio or both. There is prophylactic surgery. The example that Dr. Amina had given for Angelina Jolie means that remove all the at-risk tissue or organs that have a potential of developing into cancer in the future, especially in those patients who carry genetic mutations. Then we have reconstructive surgery, which restores appearance or function after cancer removal, such as breast reconstruction after a mastectomy. and supportive surgery as well, like placing ports for chemotherapy. The traditional surgery involved open surgery at all times. This involves one large incision to access and remove the tumor. I remember our lecturers telling us guys that big surgeons make big incisions. Now we're changing from that towards minimal invasive surgery, which is performed through small incisions using specialized instruments and camera, which help in faster patient recovery and less pain, such as laparoscopic surgery or keyhole surgery, which is present in the country for the past maybe 20 years now. Endoscopic surgery involves using a camera to go in through the orifices and either get a biopsy or resect. Then we have radical versus conservative surgery. Radical surgery is an extensive procedure that removes the tumor along with a wide margin of normal tissue. For example, radical mastectomy. That means that if we're undergoing a radical surgery for the breast, it means you are removing the entire breast. While conservative surgery preserves as much healthy tissue as we can possibly get. For example, breast conserving surgery. So role of neoadjuvant therapy. Neoadjuvant therapy is the chemotherapy or radiotherapy or a combination of both, given before the surgery to shrink the tumor, making it easier to remove. Sometimes we are able to excise the tumor with good margins, but we will leave the patient with a large defect. Sometimes we give the patient chemotherapy first to shrink the tumor to a manageable size, and therefore that's called downsizing, and therefore you're able to resect the tumor or the growth or cancer with negative margins again, but you don't leave a wide enough defect. You may also convert a radical procedure into a conservative surgical procedure. So the response assessment that helps determine how the cancer responds to a specific therapy. So adjuvant is treatment now given after the surgery. So don't be surprised sometimes in cancer treatment you'll get chemotherapy before surgery, then you undergo surgical procedure, and then you're given chemotherapy after. It's often called the sandwich therapy, sandwich chemotherapy. So it destroys any remaining microscopic cells. The goal is to reduce the risk of cancer to come back. That's called recurrence. The deciding factors are based on the type of cancer, the stage, and other patient or individual factors. So in surgical planning and risk assessment, there's a pre-operative evaluation, which is a thorough assessment of the overall health of the patient, the functional status, and all the pre-existing conditions. Then the tumor characteristics and the shared decision making is made between the multidisciplinary team as well as the patient and their relatives. I think just the last few slides. Palliative surgery is to only improve the quality of life for the patients with an incurable or advanced cancer. For example, if a patient has lung cancer and has developed something called a pleural effusion, that means that the chest has filled up with fluid which has compressed the lung and the lung is unable to expand. We often put a chest tube to drain that fluid so that the patient is able to breathe better. So it's not a curative procedure, it's a palliative procedure for that patient to improve the comfort of the patient. So common indications are relieving bowel or urinary obstruction, controlled bleeding, and alleviating pain, and treating wounds which would otherwise be difficult to treat. So what's the future of surgical oncology? We are looking towards a patient-centered, evidence-based treatment plan. So we have advances in minimal invasive techniques due to continued development of robotic and endoscopic procedures. Endoscopic procedures we have caught on. Robotic surgery is still not a very far dream. And we have enhanced integration with systemic therapies and focus on patient outcomes. So in summary, surgery remains a cornerstone of cancer treatment, playing a critical role in diagnosis, staging, cure, and palliation. And we have the multidisciplinary team approach these days, which ensures that patients receive the most comprehensive and effective care. And there is hope on the horizon, like Dr. has said. We have reducing incidences and prevalences of cancer because of our continued fight against the same. So I'll leave it at that, although I was supposed to deliver some of this presentation in Punjabi, which I can sort of try for the benefit of those who might not have followed through in the conventional presentation. So ਜਦੋਂ ਅਸੀਂ ਕਹਿੰਦੇ ਆ ਕਿ ਆਪਾਂ ਕੈਂਸਰ ਡਾਇਗਨੋਸ ਕਰਨਾ ਆ, we're talking about ਕਿ ਅਸੀਂ ਕੈਂਸਰ ਸੈੱਲ ਦੇ ਵਿੱਚ ਕੈਂਸਰ ਟਿਸ਼ੂ ਦੇ ਵਿੱਚੋਂ ਛੋਟਾ ਜਿਹਾ ਸੈਂਪਲ ਲੈ ਕੇ ਉਹਨੂੰ ਮਾਈਕਰੋਸਕੋਪ ਦੇ ਨੀਚੇ ਚੈੱਕ ਕਰਨਾ ਹੈਗਾ। ਉਹਦੇ ਨਾਲ ਅਸੀਂ ਕਨਫਰਮ ਕਰ ਸਕਦੇ ਹਾਂ ਕਿ ਅਸੀਂ ਕੈਂਸਰ ਨਾਲ ਡੀਲ ਕਰਦੇ ਹਾਂ ਕਿ ਕੁਝ ਹੋਰ ਚੀਜ਼ ਨਾਲ। ਬਾਕੀ ਆਪਣੇ ਲੈਬ ਟੈਸਟ ਹੈਗੇ, ਆਪਣੇ ਜਿੱਦਾਂ ਇਮੇਜਿੰਗ ਟੈਸਟ, ਅਲਟਰਾਸਾਊਂਡ, CT ਸਕੈਨ ਔਰ MRI, ਉਹਦੇ ਨਾਲ ਸਾਨੂੰ ਪਤਾ ਲੱਗ ਸਕਦਾ ਹੈ ਕਿ ਕੈਂਸਰ ਆਪਣਾ ਕਿੰਨਾ ਸਪਰੈਡ ਹੋਇਆ ਹੈਗਾ ਤੇ ਕਿੱਥੇ ਤਾਈਂ ਗਿਆ ਹੈਗਾ, ਕਿਹੜੇ ਆਰਗਨਸ ਨੂੰ ਅਫੈਕਟ ਕੀਤਾ ਹੈਗਾ। ਉਹਦੇ ਨਾਲ ਅਸੀਂ ਟ੍ਰੀਟਮੈਂਟ ਵੀ ਪਲਾਨ ਕਰ ਸਕਦੇ ਹਾਂ ਕਿ ਆਪਣੀ ਟ੍ਰੀਟਮੈਂਟ ਡਾਇਰੈਕਟ ਹੋਏਗੀ ਟੂਵਰਡਸ let's say palliation के patient दी comfort वास्ते कल्ली के असी treatment provide करनी हैगी या to सारा cancer नु करना हैगा body दे विचों। Thank you.
Hi again. For me, I'll speak about what I do, which is medical oncology. So Doc has spoken about surgery, surgical oncology. We can go to radiation. I don't do that, but we work as a team. So that is mostly radiotherapy and chemotherapies. So radiation, this is high energy treatment, X-ray treatment actually, that is used to kill cancer cells. What it does is we target that radiation to the tumor. It damages the DNA of the tumor, and automatically that tumor dies off or the cancer dies off. It's very local treatment. So for example, if a patient has cancer that is widespread in the body, radiotherapy is only going to target a specific point. It's not going to deal with the whole body in terms of controlling the disease. So it's a very local treatment. That being said, the side effects are going to also be local side effects. One is swelling caused by inflammation due to the delivery of the radiotherapy to the specific areas. The other is skin changes. Patients find that the skin where the radiotherapy is being delivered can turn a bit dark. Some get a level of degree of burns because of that radiotherapy treatment. And the other is fatigue. So this is a universal side effect for any radiotherapy that is going to be delivered, especially over an extensive period of time. Chemotherapy. So there are a lot of notions and misgivings about chemotherapy as a treatment modality in cancer care. I would say, unfortunately, it is a necessary treatment in this day and age, despite the advancement that have been made in cancer care. We use chemotherapy in multiple cancer types, subtypes, and it's used for different reasons. One is to cure the disease. The other one is to control the disease, to palliate the disease, give a good quality of life, paradoxically that being said. So it can be given as a tablet. A lot of patients these days would come and ask, do you have an oral chemotherapy? Unfortunately, the side effects are still going to be almost the same. It is often given as an IV infusion, that is through a vein. Do we have a cream? Yes, we do have a cream. Very rarely used, but yes, there's a cream chemotherapy as well. So most of the side effects, again, universal, it's going to be fatigue. The nausea and the vomiting depends on the treatment, the specific drug that's given. Fortunately, in this day and age, there are a lot of ways to support patients through these treatments. So rarely do we see a patient coming in because they're vomiting too much. Nausea, sometimes it's unavoidable, but we have a lot of supportive medication to support patients through this treatment. Hair loss, it's expected for most chemotherapeutic drugs, but not all. So these are things we would discuss with our patients, expected side effects, and sometimes hair loss is not one of them, but again, it is expected in a lot of chemotherapeutic drugs. Mouth sores, again, depends on the medicine, and pain. Pain, I'd say more of a muscular sort of pain or joint pains. Again, we support all these side effects we are able to support so that we are able to deliver this treatment, which we believe has been able to cure, control the disease for very many patients. We now have targeted therapy. Again, this is important to know because this is where cancer is moving towards. So targeted therapy, to put it simply, sometimes we find a driver for the cancer process. So, we've diagnosed the cancer, it's gone to the pathology team, they've looked under a microscope and they've seen this is a cancer, and so beyond that, we are able to run further molecular tests. These molecular tests are going to identify or try to identify if there's any target, any mutation that is driving this cancer process. And what cancer researchers have been able to do, they've been able to formulate drugs and come up with drugs that are switching off these mutations that are driving the cancer process, hence the targeted treatment. We are targeting that specific mutation for this disease. So it's still a young field. Some cancers do have this targeted treatment, specifically lung cancer. So we do have to test for these mutations. Some breast cancers do have this targeted treatment. So for most cancer, we've not been able to run away from chemotherapy. So some of the targeted treatments that we have are hormonal treatment, very common in breast cancer and prostate cancer. So that would be the anti-estrogen treatment, anti-testosterone treatment. Angiogenesis means essentially the formation of new blood cells. Cancer cells are this is how they spread anyway, by forming new blood vessels. So we have drugs that switch off that process of forming new blood vessels. We have now immunotherapies. I can say it's almost the new frontier of cancer treatment. It is accessible in our country. So what immunotherapy is, it's drugs that reactivate the immune system to identify the cancer cell and kill it. Most cancer cells are able to evade the immune system. So what immunotherapy does, it's switching back on that immune system. We have monoclonal antibodies, very technical, but essentially what it means is that cancer cells have antigens or markers on their surfaces that you can identify, or at least we can identify through different sorts of tests. And the monoclonal antibodies, they go and target these markers and kill off the cancer cells. So all those are form of targeted treatments. We have all of them locally, and we are able to either cure our patients or at least give them some long-term disease control. So as I mentioned, hormonal treatment, we use it a lot for breast and prostate cancer. The side effects, of course, depend on the drug that is used. These hormones that we're switching off, they always have a role in the body. So if we're switching them off, the patient is going to feel the effects of that hormone being dysregulated. Coming to supportive care services, we have psychosocial. For us in our unit specifically, we have a psycho-oncologist. Cancer treatments or diagnosis is such a journey from the point of diagnosis to the point of treatment, whether patient is on remission or they're on long-term chronic treatment. And we've just been able to identify that it's a gap. We didn't have someone to take care of this patient, so very important psychosocial support. Rehabilitation, we have the lymphedema therapy. So a lot of breast cancer patients who've undergone armpit lymph node removal, they end up having swelling, up to 30% of patients, swelling of the arm, which we call lymphedema. So these are just some rehabilitative services that we can help these patients with quality of life, physical therapy, occupational therapy. You know, some patients unfortunately have to undergo procedures like amputation. So these patients need rehabilitation and occupational therapy as well to help them adapt to the new life post-treatment. Speech therapy, some head and neck cancers. You know, patients have undergone treatment, especially radiotherapy. It causes mouth dryness, reduction of saliva. That can bring a problem with speech phonation. So speech therapy comes to be important. So all these are rehabilitation services that can be offered to our patients. Spiritual support, you know, here we are. We do have those services as well. A lot of times when patients get this diagnosis, it sort of grounds them back to requiring these services actually and support. And finally, hospice and palliative care. Unfortunately, we are not able to cure everyone with cancer. In fact, for us in our setting or in Kenya, a lot of patients present very late with the disease. So we are tied into what we can offer them to cure the disease or even control the disease. And at that point, what is most important is dignity of life, supportive life, and to keep them comfortable. So hospice is coming up. We have a few hospice centers in Kenya and in the large towns. I know, you know, central in Nyeri, there's one. I wish there were more because, again, as I mentioned, we are having patients come to us quite late. So that will be the best form of care to offer them. So what is complementary and alternative medicine? This comes up a lot because we are still trying to create awareness about this disease and what the conventional treatment can offer, but patients do come and want to know what is alternative medicine. This is a group of diverse medical or healthcare systems, generally not considered as what we've discussed today. So a patient will come and say, you know, I have this herbal product, I've been brought from, I don't know, anywhere outside the country. I read this on the internet that it may help with cancer control or my nutrition or my immunity. What I'd say is to just encourage anyone who knows someone going through this journey to always disclose that to us. One is that there's not a lot of research into alternative medicine with conventional medicine that has been shown to work together especially. So, you know, we may be giving or offering our treatment and a patient is behind the scene taking something different, and with an interaction we are either causing harm or we are causing inefficiency of whatever treatment we are trying to deliver. So it has a role, you know, some of this has a role. Acupuncture has a role in terms of the side effects of chemotherapy, so it's always important to discuss. But so far, unfortunately, we've not been able to come up with an alternative treatment that can cure this disease. So complementary versus alternative. Complementary is what would work together with conventional medicine. I think I just mentioned acupuncture for pain management, while also being on our treatment like chemotherapy and whatnot. And alternative is in place. So that is what I was talking about, herbal medicine, or any other traditional medication that is used, or even dietary measures. We have patients that would say, I'm going to do juicing of specific vegetables and this has been shown to cure cancer. That's not true. It's not true, unfortunately. I wish it were, but you know, using that in place of treatment that has undergone rigorous research on many millions of patients throughout the world, it's important to discuss with us. So some of the complementary health approaches that have been shown to be beneficial, we have nutrition. I'll speak a bit about that. Supplements, meditation, chiropractic, acupuncture, and massage. So the others are almost self-explanatory. You know, the massage, acupuncture, I've spoken about that. Meditation for mental wellness. Nutrition and supplements, we insist on a balanced diet as cancer doctors. wholesome, balanced diet. I'd say normal Kenyan diet would be ugali, skuma, and maybe a protein to that. That's adequate. You find a lot of patients when they're going through cancer treatment, they lose their taste buds, or there's bluntness of food. So telling a patient you cannot eat this particular food group, and 3 weeks later this patient comes back to you with 5 kgs lost, that already is making it very difficult for us to deliver any further treatment, which can be quite toxic. So no food has been shown to be curative for cancer, or even to accelerate the cancer process. So what we insist on is a good balanced diet. That being said, obesity has been implicated through research to cause cancer, breast cancer specifically, and other types of cancers. Red meat specifically, it is recommended not to be taken more than twice in a week. So that may not be so much of an issue with us here, but it's just good to have this information. We can also share with people around us, our colleagues and friends as well. I think, that, just that a balanced diet, no specific diet this is for cancer. It's going, patients come and say, I've been told not to eat sugar, it's going to cause the cancer to grow. That's not true. Not unless, the person is actually taking significant amounts of sugar. But, 2 teaspoons with a cup of tea is quite okay. So I think we've discussed the possible benefits of this kind of approaches. Risks, again, I mentioned, we don't have very many studies to say this particular route is more effective than the conventional treatment, or it works better. If you take a beetroot every day of the year, it's going to be more beneficial than not taking at all. We don't have research to actually guide us on that. And it can actually cause harm. We know patients who've been taking green tea and, in 6 months' time, they come with acute liver failure. They've been taking maybe 3 cups of green tea per day continuously, because they read somewhere on the internet it has this and that benefit. Can actually harm the patient. And of course, it can interfere with the drugs that we give. So I mentioned, if we knew what you're taking, this supplement that has been shown to do one thing or the other, and it's interacting with this chemo that I do know it's going to shrink the tumor, one, it's either not working because of the interaction of these 2 agents, which is not useful to what we are trying to achieve. So I think that's my last slide. I just invite back Dr. Chana to moderate the Q&A session and to finish off. Thank you.
So, ladies and gentlemen, I'm sure you've heard a lot, and I'm sure you're a bit more well informed now. Our hope is that this knowledge ripples out. Sadly, we cannot be everywhere at the same time, but we're hoping that you all in this room can be champions of advocacy, and with this knowledge be empowered to share. You've heard a lot about cancer. We'll take some time to even get your questions and answers, to also shed on important myths and misconceptions that maybe are present. We can shed light on that. But before that, I would like to have a call to action. Each bit of this knowledge can propagate into more. And we've heard what to do and what to avoid. So I'm hoping we can take home these important messages. I'm hoping we can now, ensure we can implement them. We can be advocates and even practice screenings. This month is October. This month of October is Breast Cancer Awareness Month. Many hospitals and many areas have these services like mammograms, ultrasounds, pap smears, even the prostate-specific antigens, being done, even at a subsidized price. All it takes is even just going every October just to do these, like for mammograms every year, for pap smears and HPV testing even every 3 years. Um, if found early, you've heard, through the various treatments, these conditions can be cured. On the other hand, sometimes these things can be silent, they can't be caught early, and that's when a bit more aggressive treatments are implemented. These treatments, however, the side effects are nowadays being very well managed. The priority when we see a patient in the hospital is their safety and their utmost well-being. That's to address all their biophysical needs, their mental needs, their spiritual needs, even their financial capabilities. We only give treatment when we see it's fit, when it's safe, when it's fit for them, and we cannot cause a lot of, additional burdens. There's always discussions that are present with the doctor that is not only one time, but it's continuous. And you've heard breast cancer alone, but all of these cancers get treated by more than one doctor. So it's a collaborative effort that we always try to implement from the word go. So we're hoping all this, propagates to change. I think it's important. Sometimes we're always worried about. Even today, I was worried about, are people going to come? How many people have come? But I think what's important is, no matter the people, it's always the quality of even that single person just having a change in their life. It's always about quality and change rather than quantity. And I think that's important. So with that, I would like to end the statement by saying, together, through awareness, prevention, and early detection, we can actually save lives. Be informed, be proactive, and please be the voice of screening and early detection. Thank you. So I now open the floor to you all. Please feel free to ask questions, direct them to any one of us. After this, we will also allow Guru Nanak Hospital, our attached hospital, to also discuss some of the services they have and also the efforts they are implementing. Today we've set up a small booth on the side in the classrooms where you can get general health checks. You can also talk to us in case of any issues. There's also a blood donation drive. It's very important. Some of the chemotherapies we give, they target rapidly multiplying cells in the body, cancer being one of them, but another is blood. Sometimes the blood cells drop with time, even with the disease. So each single pint you give today, with all the different blood components, can actually save 3 lives. So blood, one unit can save someone with cancer, can save a child, someone who's done surgery, someone who's delivered and is bled a lot. So not only are we helping patients affected by cancer, but patients worldwide. So I'd really encourage all the healthy people here to also donate blood. Thank you.
Thank you so much, doctors, for all of the knowledge that you've given us this morning. Of course, if you have any questions, now is the time. The floor is open for a Q&A. We've got one here. So, Sahib, maybe you can just project your voice and ask the question. Uh-huh.
Thank you, Saib, for that question. Like I mentioned, grade means the extent of changes in the cell when you compare that cell to the original. For instance, prostate is supposed to be made of glandular tissue, right? So if the prostate has undergone cancer change that has not altered too much of the cell type, it looks just like prostate cells, but they are multiplying abnormally, all right? That we can say probably grade 1, okay? But if it has over the years, because time is of essence, a grade 1 tumor takes longer to spread than a grade 4, grade 3 or grade 4, okay? So when you're talking about stage 4 of a grade 1 tumor, that's probably cancer that has been there for a very long time. So that's, you can say it is as bad because we're dealing with spread to distant organs. Like for instance, if it's prostate, it often spreads to the bone. So if it's spread to the bone, the backbone or the pelvis, we are talking about a stage 4 disease. The treatment for that will be treated as a stage 4 disease is treated. So that involves upfront chemotherapy and maybe palliative surgery. So when we're talking about a distant spread, we're not talking about curing the patient or curative treatment. We are having now these directed approaches that Dr. had mentioned, all right, towards controlling the disease, keeping the patient, if in remission at all right, for as long as we possibly can, and providing the best supportive care.
So, in terms of caregiving support or support to the caregivers, so number one, I want to emphasize that cancer has really, really become a big concern for all of us. The numbers are going to increase. You know, it's projected by WHO by 2030, the numbers would triple what we have right now. So, you know, one of us, we are all going to be affected, whether it's by friend, colleague, family member, or even one of us, actually, unfortunately. So, number one, it's very important to speak clearly for us. So, this is to us as clinicians, to speak very clearly to the patient and the family regarding the expectations of, you know, this disease, what we are trying to achieve, and to be very honest and practical about it. So knowledge is power, and then, you know, from that point on, we can each manage our expectations. The second thing I mentioned, in our unit specifically, we do have psycho-oncology sessions. So it's mandatory, every new patient who comes to our unit has to go through the psycho-oncologist to be assessed and sort of as a baseline to know where we are starting from. So this is often offered with a caregiver in place, just so that they can also understand their role. It's useful to have a helper, a caregiver helper. So, you know, it's a lot for anyone, and to take breaks so someone else can step in. Again, there are healthcare services, hospice cares, palliative care. We have a program for home care nursing as well, because, you know, patients may be suffering from, you know, they may be having a stoma, for example, a stoma bug. They're not able to change this as a caregiver as well, for one reason or the other. So, you know, right now we have a lot of home care nursing services. Doesn't have to be with our institution. So to always seek help. And as you know, as part of our training, we are trained to understand it's such a long journey. It's very tasking for the patient and the family caregivers. So how we interact and how we have our consultation sessions is to include, in fact, I specifically remember I would not see a patient if they're not coming in with a family member. In most cases, yeah, just because you want to include everyone in this, and we know what lies ahead. Yeah.
Just to also add on, The caregiver's role is very important, but also very stressful. Why it's important for the caregivers to accompany the patient is the patient is already stressed because they're directly impacted, but the caregiver also is there to assist in processing some of this very stressful news. Sometimes everything flies over the head of the patient, so the caregiver supports that. It's very stressful because sometimes, most of the times, the caregivers make some of the decisions. They also try to mobilize the resources for these patients. It's very tasking, and we do recognize that sometimes even they're more stressed than the patient. So getting that counseling service for them is equally as important. Also, those breaks, they're very understandable because at the end of the day, the patient and the caregivers are humans, and they also have to get at least some stability before taking care of someone else. So taking care of yourself before you take care of someone else is the narrative.
Thank you, doctors. Do we have any other questions from the audience? Anyone with a question? I'll just repeat the question for the people at the back who might not have heard. Just by summary, where someone has family members with a history of cancer, what can they do to be proactive? And maybe you can answer that first part of the question.
So when we are starting off with a cancer patient, we usually take a family history, and some histories are suggestive of a lineage of cancer in the family or a risk for someone else to get that cancer as well. So we have a cluster of cancers: ovarian, even stomach. So in this day and age, we don't stop at just pathology, this is cancer. We go further ahead and do more sophisticated molecular testing. And these tests can identify genetic mutations that are familial. So with that, we are able to advise, and we do it routinely for all our breast cancer. So there's a criteria, maybe, below the age of a certain age, below 40 years, all these patients have to be tested for any familial genetic syndromes that may guide us to what we can tell them about their family at large. So it's not just one specific cancer. Like lung cancer is very common for very many different reasons. Unlikely to be familial. Stomach cancers sometimes, but a very low percentage. But we know some specific cancer we have to test. We have to go down and test molecular, so that we can also inform the family. Doc, maybe you want to add something?
Age at diagnosis is also very important. 80% of the cancers are sporadic, means that you can just say by bad luck someone has developed cancer. 80% are sporadic, with no known risk factors, no genetic predisposition. But age is very important. If the age at diagnosis of a gastrointestinal cancer is below 55 in a first degree relative, that can be translated as suspicious of a cluster cancer. So if the age of diagnosis in a gastrointestinal cancer patient is below 55, then I would recommend that we can start undergoing screening for the same. And screening for gastrointestinal cancers are through endoscopy. So we're talking about an esophagoduodenoscopy, all right? That's OGD, as well as the colonoscopy.
And then the lung cancers are sporadic, but in such a case, the age would really be determining. There's efforts being put in screening of lung cancers, but it still involves now X-ray exposure, so that becomes a bit of a balance between exposing someone to ionizing radiation with CT scans and then close surveillance with other means.
Any other questions or follow-up questions?
Radhika, just to add on that, sorry,
Sorry,
to
go
cut
ahead.
you short. Lung cancers such as mesotheliomas could be occupational as well. So if you're in the same occupation with a family member who has been diagnosed with a type of lung cancer called mesothelioma, so that accounts for probably, to reduce the exposure from the same.
That was a really important point, Doctor, especially in our community where we tend to work in very similar sectors. We had a question. Oh, we have two. Maybe I'll ask the gentleman at the back first. Uncle, maybe you can come to the front. We can give you the mic. No problem. You can just do it.
I just want to check if the PSA level goes up, does it mean it is a cancerous, it's developing into a cancer or what?
So prostate cancer is diagnosed by different ways, but it's not just one test. A lot of men, I'd say over 90%, once they reach a certain age, the prostate gland actually enlarges, it grows big. And this is benign, it doesn't necessarily translate to it being a cancer. And that can also cause the PSA to go higher. But there's a level of PSA that is high that is suspicious. That being said, a high PSA level requires a downstream of other investigations. One is an MRI of the pelvis or even a basic ultrasound. Another thing is a physical examination. Dr. Pry can actually speak to that, what they do as urologists, and the PSA. So all that then we diagnose, is it prostate cancer or is it just an inflammation of the prostate gland, prostatitis, or is it just the enlargement of the gland without it being cancerous? So it's not a single test to say, but that can actually guide us to what to do next.
Do we have two questions here. I'll let this gentleman go first and then the lady.
Yeah, thank you. That's a very important question. So one, yes, we've been doing next generation sequencing, which is essentially the genotype, immunotype of the cancer cells. So what he's saying is, remember, once we diagnose the cancer, we can just run this test to tell us specifically, are there any drivers to these cancers that we can identify through very sophisticated tests? We've been outsourcing this for the longest time. By saying that, it means we don't have a database in Kenya to say this is our genotype of this cluster of cancers. So very small institutional studies have been done. At AKU, we had one for breast cancer, triple negative breast cancer, but it's a very small cohort of people. It's not nearly representative of the women in Kenya who've gone through breast cancer. The second question, it's very accessible right now. So and I promise this is not marketing, at Aga Khan, we are starting the next generation sequencing testing, which is genotype, what you're asking, starting from next month. So everything has been put in place, and we're going to really personalize patients' treatments. So cancer is diagnosed, you want to know everything about this disease so that you personalize the treatment to this specific patient. So maybe starting with that, which is going to be one, accessible to all Kenyans, and two, I'd say relatively affordable, we'd be able to build up a database from that. Right now with the data protection that's coming up, but again, we still have to do research with the data that we're getting. It's going to inform practice in the future years. So it's not going to be publicly available, but it's going to be published in one way or the other. Yeah.
Okay, we had a question from the lady here. This is such a relevant question, especially given the forum of the Young Professionals group. So thank you, Debbie. If maybe one of you can take that.
I think I'm the youngest in my career, but probably will transition to everyone to have a word on that. So thank you for the question, Debbie. I think for me, I have the personal experience of being a patient and a survivor. So my aspiration to do medicine stemmed from that. If I was to change things and maybe do different things differently, I don't know how much I would do. Like currently at Aga Khan, we also work at the clinical research unit. We have a number of clinical trials, mainly for oncology, but a few for neurology. It's been very interesting to actually be part of global studies that might change the treatment of cancer worldwide. We had a very interesting study the other day where if a patient was found with a specific genetic mutation called a KRAS G12C mutation, then we had a pill to block it. We screened more than I did the analysis, more than close to 90 patients. Only 2 patients had the gene. They weren't even from Kenya. It's only after the study ended we got a few patients. But it was very interesting to see how it was basically just to get a snapshot of how things are going to evolve, where if we find a driver mutation, we can block it. The same thing is being done for other studies. Like in breast cancer, there's a molecule that can really drive the cancer called a HER2 protein. And we have different studies that are blocking that HER2 protein and trying to see different combinations. So I think if I was to change things, I think is now to just progress on to leveling up in the field. Yeah. So I'll hand over to Dr. Rupra and then Dr. Amina also.
Right, thank you so much for that question. In our undergraduate training, we are taught the importance of prevention. So our program, the way it's designed, I think it is designed to fight not only cancer, but other communicable versus non-communicable diseases as well. So honestly, at this moment in time, I don't think it would, changing anything would actually make a difference from where I am right now.
For me, I'd say awareness. 80% of cancers, Dr. Rupai rightly said, are completely just bad luck, to be honest. We don't have any cause of it. You may have the healthiest of lives, the healthiest of practices, but unfortunately, someone still ends up getting this disease. So for me, it's just awareness. If we could just have that health-conscious population, people who have health-seeking behaviors, and for us to give that information as frequently as possible. It doesn't have to be screened, so it doesn't have to get to that point of early diagnosis. It could be just the regular annual screenings that people do either for the insurance purposes, and they're so affordable and accessible at this point. Even at the national hospital, the government hospitals, these screenings are being done annually at very affordable, competitive costs. So it's about awareness, knowing your body. When something changes, you can just reflect back, wait, this last year wasn't as this, so what's happening? Can we follow up with something more? So it's awareness.
If you have any other questions, do note them down. The doctors will be around for a couple of minutes after. Dr. Chana?
So this is not in the program, but I want to surprise you guys. There's a friend of mine at the back. I don't know why she's sitting so behind. I'm so glad to have her. She's called Terry. I would like her to share some of her story. The last time I actually saw her was a year ago. It was her wedding, and I believe now she's a mother. Her story is very inspiring because Terry had, you have to remind us, I think it was acute, one of the acute leukemias or lymphomas. It was very aggressive, but on top of that, she also had a very, disabling heart condition. But look at it. Now she's here. Now she's thriving. So Terry, please, maybe a few words, just so that people can really see that we do have patients out here that have been affected, but are also attending things like this. So Terry, welcome.
Hello, everyone. Hello, everyone. My name is Terry. Chana is my very good friend and invited me to come to this place, so I was not prepared to present anything anyways. But briefly, I'll tell about my story. So I got diagnosed with leukemia in 2018. And you see, in my family, we've never had something like that before. So it was a very tumultuous time for us because we did not know anything about cancer. We did not know what causes it. And most of the time, someone will tell you, oh, you're supposed to be maybe in your 60s, 70s. I was only 24. So you can imagine how I was shocked. And through the years between 2018 and 2021, I was doing treatment. And as I heard most of the doctors who are talking here, they were saying about early treatment, early diagnosis, and then you get to treatment. I think that is one thing that has really helped me. For example, I actually got diagnosed at Aga Khan Hospital, and the doctors there really held my hand, and with my family as well. They really supported me and told me this and this and this. Currently, I'm working in the cancer sector, but I work in the technology field where we create websites that give people information, because most of the time, the people who get diagnosed, they do not get the information. They don't know what to do, what next. Now that I have the diagnosis, like, is it the end of is it the end of my life? Because cancer in Kenya is something that most people, when they hear it, it's the end of your life. Like, when are you going to die? What is your prognosis? And things like that. So it is good to get the information. And what else was I supposed to say? Yes, and yes, you can thrive. You can thrive after the treatment, because I called after my treatment, I was declared not really cancer-free, but I got into remission, which is like you finish the treatment, but you have to go for checks every 6 months. And right now, as you've heard, I got married and had a baby, so that means that after... Thank you. So that means after you get the treatment and it is done on time with the right people and with the right support, you can thrive.
Thank you, Terry. Thank you so much. Thank you, Terry. And Terry has been asking me for an Aga Khan maternity bag, so I've not been able to get it. Now I need to get it for her. Okay, so I think Radhika, the floor is yours. I think we can now proceed to the end.
Thank you so much, Doctor, and thank you so much for sharing your testimony. We are at the end of our program. I'll just ask Mr. Moses Mugambi, he's from the Guru Nanak Hospital, just to very briefly outline some of the services that they offer, and that's where you can use all of this knowledge and get any checks or treatment. Moses?
Good morning. I'm Moses Mugambi from Guru Nanak Hospital here. This one being the month of October, in the health sector, we really take the month of October with great esteem. And as Guru Nanak Hospital, we are part of the initiatives that is spreading the cancer awareness. We are trying to check on how we can arrest this monster, because the cancer does not affect only one person. If one member of the family is affected, the entire community is affected. From my own front, I think I've lost like 4 uncles out of cancer. And out of that, I've been having programs wherever I am, even before joining Guru Nanak here, to take an initiative of spreading the essence of wellness, then the essence of medical checkups. The team of doctors here, these are serious faculties, they are the ones that handle us. They usually emphasize annual checkups. Each and every one of us to embrace that one and to become part of our life. I joined Guru Nanak barely 3 weeks there, and in preparation of the Cancer Awareness Month, which is October, we came up with a program. We had a think tank as an hospital. How can we approach this matter such that, there are some of us who die because we don't have information. How can we spread this gospel? And we came up with a program where all the services that are required for screening and all that, we discounted them, and they are free for the public the public is free to come and enjoy those services. And in that particular, I sat down together with a few people there. We came up with a wellness voucher. Doc, please give me 2 minutes. I hope we came up with a wellness voucher. The wellness voucher that we have, it is for I and you. I myself, I can afford to go for screenings. Probably my nanny at home cannot afford that screening. And when my nanny is affected, I'm also affected. I'll be required to look for another nanny. I'll be required to do a fundraise. The whole community will be affected. In that manner, we came up with a wellness voucher that we try to gift to the people who cannot afford or who are not aware of the screenings that we are embracing. Through much discussions, approvals and all that, we discounted the screenings from Guru Nanak. The total cost for the screening was going at 3,564. I had to plead with the management. Actually, even the president was there and the vice president, and I earned that idea. I told them, now, this is the month that we need to, we try to take it further, even to our villages, to where we work. You could be having a staff somewhere. Please, that's how we came up with a wellness voucher. The price has dropped. It was going at 3,564, but now it is going at 2,100. Kindly, I beg each one of us here, and even out there, we gift the people that we care and the people that we love. The catch line, care for someone you love, that is a question. The other side, yes, you care because you matter. Kindly, I beg all of you, we are having our tent around here. Don't go without gifting someone a wellness package, which is very much affordable. I had to struggle with the management to drop that price to where it is. Thank you so much. You are all welcome.
Thank you so much, Moses. Those vouchers will be available outside. So is a blood drive. I see a few young people in the back who I usually see in a gym. So now it's time to help others with your very healthy blood. We also have a wellness check outside. And that brings us to the end of our program. A quick vote of thanks is in order. Thank you so much to the Guru Nanak Hospital for all of your support throughout this program. Also, thank you to the EARB. Thank you so much for all of your support. And a big thank you to our speakers. We'd like to just give you a token of appreciation. So if I could please call upon the EARB Pradhan Surinder Singh Sira to give a token of appreciation to Dr. Ruprai. We've got a lovely certificate, a token, and some flowers for you, Doctor. If you could please appreciate the doctor with a round of applause. Thank you so much for all of your time and all of the knowledge that you've given us this morning. Thank you so much, Doctor. I'd like to ask the Vice President, Mr. Manminder Singh Jandu, to please present a token of appreciation to Dr. Amina. Again, we've got some lovely flowers and a token for you. Thank you so much, Doctor, for all of your knowledge. Lastly, I'd like to call the Honorable General Secretary, Mr. Kamaljit Singh Sira, to present a token of appreciation to Dr. Chana. Dr. Chana is part of the YPG. He is the reason why this event happened. He planned the entire event, all of the slides you see, the posters, the idea, down to the pink decor. Dr. Chana, you're such a valuable part of our group. And thank you so much for all of your efforts this morning. Thank you so much. And lastly, thank you to everyone who joined us this morning. And thank you so much for your time. If you'd like to join the YPG, please you can come talk to me and I'll introduce you to our president. And you can join us. If you have any children who are young in their profession, this is the place to be when it comes to networking. All right, that brings us to the end. As we leave, I'd ask the president and all of EARB to just come to the front. We'll take some photos.